Hello everyone and welcome back. Today we are studying dissociative disorders. I am Michelle and I will attempt to cover everything you need to know at the level of a final year medical student. Here is a basic breakdown of today's presentation. Dissociation is the protective psychological process for managing overwhelming or conflictual affects and experiences. Clusters of mental content may be split off from conscious awareness or ideas that are separated from emotional significance and affect. There could be a loss of integration and/or a loss of connections. Loss of integration refers to the cognitive awareness and control over your own mental processes. Loss of connections refers to the connections between memories and their emotions and your perception of self and the environment. The loss of these connections result in confusion about one's identity and alternating discordant behavioral states. Dissociation is the brain's way of handling difficult information such as traumatic events, childhood abuse, information that is in conflict with experiences and expectations, or information that is too difficult to bear. It is the mind's escape when physical escape is not possible. Cognitively, dissociation reflects an information processing style where multiple streams of information is processed simultaneously but is not integrated during times of threat. Developmentally, dissociation is the pattern of mental organization resulting in the integrated sense of self and connections between mental processes which never developed properly. This is usually due to a chronic complex trauma or childhood abuse. Dissociative symptoms include derealization, depersonalization, identity confusion, amnesia, and flashbacks. Identity alteration is a more severe form of identity confusion. This is the discovering fully dissociated activities of another self-state, with pronounced variations in how a person relates to the world. Switching is the sudden change or shift in executive function between different self-states, identity states, or you can also call them alters or alter personalities. This can be dramatic or subtle, and the new identity state or alter can exhibit completely different characteristics. This includes their way of speaking, their accent, posture, mannerisms, and even the adoption of the opposite gender. Dissociative identity is referring to the observable phenomena, the sudden subjective experiences of self-alteration by the patient, and objectively an observable behavior by the onlooker. This results in the presence or activities of the dissociative identities, which manifest as sudden feeling or behaving like a different person, switching between feeling and behaving like a child or adult, and switching between feeling and behaving like a man or woman. These may present as time loss, being told of one's actions with no recall of such, finding evidence of recent behavior such as broken mirrors without any recollection, as well as variable co-consciousness. This is when the patient is aware that there are other identities that occupy the same mental space. So, dissociative disorders is the brain's incredible ability to subdivide or compartmentalize the mind, DID being the most severe form of this. However, this causes clinically significant impairment, resulting in significant problems with awareness, consciousness, or sense of self. The characteristics of dissociative disorders include disruption or discontinuity in the normal integration of consciousness, memory, representation, motor control, and behavior. A severe form of this leads to breaks in consciousness, where the patient is unaware of behaving in contradictory ways as if controlled by different forces at different times. There is marked discontinuity in the sense of self and agency, with alterations in affect, behavior, consciousness, memory, perception, cognition, and sensory and motor function. Clinically significant dissociative processes, symptoms, and defense mechanisms. A patient is diagnosable as mentally ill when any area of functionality is adversely affected. Clinical presentation of a patient with dissociative disorder. So patients with DD usually present with secondary symptoms and not with primary symptoms of distinct personality states. These secondary symptoms include psychosomatic symptoms, unexplained injuries, eating disorder or substance abuse, incongruent affect, or abrupt changes in mood, including that of anxiety. There are different types of dissociative disorders, namely that of dissociative identity disorder, dissociative amnesia, depersonalization or derealization disorder, other specified and unspecified dissociative disorders. Dissociative amnesia is the inability to recall autobiographical information that is inconsistent with normal forgetting. Amnesia can be localized to an event or period of time, it can be selective to a specific aspect of an event, or it can be generalized. This includes amnesia of one's identity and life history. What also falls into the category of dissociative amnesia is a purposeful travel or bewildered wandering known as the fugue state. Depersonalization or derealization disorder is a clinically significant, persistent, or recurrent depersonalization and or realization. It is also important to note that in patients with this disorder, their sense of reality is still intact. Other specified dissociative disorders refers to prominent dissociative symptoms not meeting the full criteria of any other specific disorder. It's the chronic or recurrent mixed dissociative symptoms falling short of DID diagnostic criteria, and the dissociative states secondary to brainwashing or thought reform. It could be acute dissociative reactions to stressful events or a dissociative trance. Unspecified dissociative disorder is the prominent dissociative symptom not meeting the full criteria of any specific disorder, or there is insufficient information to make a more specific diagnosis. To diagnose a person with a dissociative identity disorder, we use the DSM V diagnostic criteria. This includes criterion A to E, and every one of them must be met. Criterion A: disruption of identity characterized by two or more distinct personality states, which may be described in some cultures as an experience of possession. The disruption in identity involves marked discontinuity in sense of self and agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and or sensomotory function. This is observed by others, or it can be reported by the individual themselves. B. There are recurrent gaps in the recall of everyday events, important personal information, and or traumatic events that are inconsistent with ordinary forgetting. C. The symptoms cause significant distress or impairment in social, occupational, or other important areas of life. D. The disturbance is not a normal part of a broadly accepted cultural or religious practice. And note, in children, the symptoms should not be better explained by imaginary playmates or fantasy play. And lastly, the symptoms are not attributable to the physiological effects of a substance or another medical condition. So, what causes DID and what is the pathogenesis? An important step in childhood development is the forming of a central integrated consciousness. This process is impeded or prevented by chronic trauma in the development of DID. The child uses radical denial and splitting to cope with the traumas, imagining that the traumas happened to someone else. The child's fantasy capabilities and imagination give the different personality states their individual characteristics. Extremely inconsistent and contradictory behavior by attachment figures and the denial of the traumas suffered by the child additionally foster the dissociative coping strategy. It is also important to note that DID does not develop beyond 6 to 9 years of age. Other dissociative disorders include PTSD, PTSD with dissociative symptoms, and dissociative amnesia with dissociative fugue. Here is a table of the differential diagnosis and the similarities and or differences between them. Psychotherapy is the mainstay of management or treatment of patients diagnosed with dissociative disorders. It is split into 3 phases. Phase 1 is stabilization of the patient. Phase 2 is working on the patient's memory, and phase 3 is helping the patient integrate back into society as a normal functioning, independent person. Pharmacologically, we use pharmacological drugs for stabilization and treatment of comorbid conditions, and we only treat for the target symptom found in most or all alternate identities. And that brings us to the end of today's presentation. I hope that helped. Please leave your thoughts in the comments below. Let me know if I missed anything important or if I made any mistakes. I hope to see you next time, and good luck for exams.